Hi, I just pooped my pants. Hello to all of you beautiful birthing people. Welcome back to my channel. My name is Elizabeth, also known as Nurse Zabe, here on YouTube and Instagram, and this is Miss Rosalie, who is 3 months young, living her best life. I was thinking she was going to be taking a little nap in her bassinet, but girlfriend had other plans. So she's going to join us for this video, which is going to be a Q&A with a labor nurse video. I obviously just had a baby, so working back into making YouTube videos, kind of starting things off pretty easy, but I have a lot of really exciting content coming for you guys, including a tongue tie video with Amy from AZ Breastfed Babies that hopefully will be the video that comes up after this. We are filming that tomorrow together via Zoom. So without further ado, let's go ahead and jump into the questions. I also feel like I look like I'm naked, but I am wearing a shirt, just so everybody knows. I'm going to start off with a little bit of a spicy one. Can you request a new nurse if you don't like your nurse and aren't getting good vibes from your nurse? So basically about firing a nurse. And I have talked about this in a couple of other videos, but I want to reiterate because it is so important. We are not going to get along with every single person in the world, right? There might be personalities that don't mesh. It's totally fine if you and your labor nurse don't mesh, if the vibe is not feeling right. This is a really important time in your life. So if you're wanting to request a new nurse or make a request not to have that nurse again, or, you know, God forbid something actually happens that's like not safe that you need to let somebody know about, the best thing to do is to go and speak to the charge nurse. So you can ask for the charge nurse to come to your room, but if you're trying to be a little bit more sly about it, like you don't want the nurse to know that you don't like her, but you just don't like her, and that's okay, then have your birth partner or whoever's with you go out and ask for the charge nurse at the nurse's station, or go out and find the charge nurse specifically. And the charge nurse is going to be typically the one who does room assignments, so you can let the charge nurse know what's going on and say that you are requesting another nurse. Now obviously if something unsafe is going on, that takes the utmost importance and we need to know. But yes, you can get a new nurse if you guys are not vibing. Ideally, if it's just a personality thing, not letting your nurse know is nice, because that can be something that would really hurt the nurse's feelings. But if there is some rudeness going on, if there's some condescension, if there is something unsafe going on, definitely verbalizing that to the charge nurse so that she can then either go up a chain of command if that needs to happen with something unsafe, or can, you know, kind of gently talk to the nurse, or just switch things around and not let the nurse know, depending on what's going on. So here's another one that I wanted to answer because I feel like this is something that just isn't super well known. So do labor and delivery nurses typically stay in the room to support, or more come and go and check in? So this is going to depend on a few things. So there are some places that do like 1,000 births a month or even more. And so their typical staffing might be 2 labor patients per nurse. So they might be doing more coming in and going out and checking in. There are also places where the focus is really making sure that the nurses are present. That is a place where I work. I am lucky. We do a couple hundred births a month, and our focus is really being with the laboring person. And so that is something that we pride ourselves on being able to do, is being able to provide, if needed and wanted, hands-on support. Now, not every nurse is going to be an expert on unmedicated births or hands-on support in that way. Some of us really, really like it, have done additional training in it. And so if that is your goal, you can always request a nurse who is really familiar with unmedicated births, if that is what you're going for. But even if you have a medicated birth, it's really great to have a nurse that is able to kind of be with you and to be in the room with you. Now, I also really try and read the room and figure out, is my presence helpful or is my presence unnecessary and hindering things? Because so much about birth is about the environment and having a good environment. Some people really thrive in the privacy. They don't want additional people in the room unless they're needed. So my goal really is to always kind of be reading the room, and yes, sometimes I read it wrong, and then to not just be watching somebody labor, but to be present in a way that is useful and helpful. And if you're needing your nurse to be more present, let them know. They might be thinking that they're in the way when you actually want the support. If you're needing the nurse to be less present, let them know that too. Ask them to go get you water, or labor some in the bathroom with the door shut. You know, we try to do our best. We try and read the room. We try and also keep things safe from a staffing perspective as well. So it really is going to vary, but you definitely can request for your nurse to be more in the room if you need them. Here's another one. This one, we're going to move on to some cesarean birth questions. Hi, I'm due with my second C-section and wondering if they will cut over my first scar. Yes, and they will kind of tidy things up if they need to. If there's a little bit of extra skin with that scar, they'll remove it. They'll make sure that you just have one incision. You're not going to have 2 incisions on top of each other. And so if you're ever concerned about that, or about how your last C-section scar healed up, that is a great thing to talk with your OB about. If you developed a keloid scar, if you're prone to keloid scars with your last one, there are medications that they can give you after the cesarean into your scar to help reduce that risk of keloid scarring. Okay, sorry about that, guys. We had to take a little boob break, and I thought we were gonna take a nap. And as soon as I laid her down, she was back up. So Rosie's going to be joining us facing out for the rest of this video because I don't have that much time to film now. Next question. What are reasons to use oxygen in labor? I had it and have no idea why. This is actually very interesting. So when I first started as a labor nurse 8 years ago, oxygen was something that we did for a lot of patients. And so the reason why we would give oxygen in labor, theoretically, right, the idea was we can better oxygenate you and baby will then get more oxygen as well. So we would put like a non-rebreather mask on at 10 liters if baby was having a deceleration in the heart rate, showing us that there was some compromise in their oxygenation. But now what we know is that if your oxygen saturation is above 95%, so 95 to 100, which is what most of us are when we're breathing, providing supplemental oxygen during your labor doesn't actually do that much good. And long-term use of supplemental oxygen can increase free radicals, which is actually can have negative effects. So we don't do it as our first line of defense with a heart rate deceleration as much anymore. Now, this research is fairly new and it takes like 20 years for that to kind of trickle down and change practice. So you might still get oxygen in labor, but it shouldn't be necessarily the first thing that they do. And it should be mostly only done if your oxygen saturation are low, and that would be affecting the oxygenation of the being inside of you. So some other things that we might do if there's a deceleration in the fetal heart rate is change your position from side to side, or even get you on hands and knees. We could potentially put in a intrauterine pressure catheter to put more fluid back up inside. We could also potentially give you a bolus of IV fluid to help with the fetal heart rate. And they might still put oxygen on, but it's not something that should be left on for a very long period of time. Here's another one. If test positive for GBS, is that a reason for the doctor to not let me move around or walk during labor? No, not at all. So first off, let's say, what is group B strep? Or GBS. GBS is group B strep, which is a normal bacteria that is found in about 25% of the population's normal vaginal perineal flora, normal bacteria. This bacteria is living its best life. It's totally fine. But when your brand new little bean emerges from your birth canal, they can get colonized and then subsequently infected with group B strep, which can cause a group B strep infection, which can potentially be fatal for your babies. And so if you are group B strep positive, which they'll check at about 36 weeks into your pregnancy, then you will get antibiotics during labor to reduce that group B strep so that your baby does not get colonized and potentially infected with group B strep and have a group B strep infection in those first 6 days of life. Now, because you are going to need antibiotics, it will be IV antibiotics, so you will have to be hooked up intermittently to an IV. But even being hooked up to an IV does not mean that you cannot walk and move around by any means. First off, it's going to be an intermittent infusion, meaning it's not going to be hooked up all the time. So even if you wanted to be in the bed while it was infusing, you would have other moments when you weren't going to need the infusion. The other thing is IV poles literally are on wheels for a reason, so that you can boogie your thing around and move and change positions and walk and bring that pole with you if you need to. So being group B strep positive in and of itself is not a contraindication for movement in labor, even a little bit. The two are not really related. Here's one that is a little bit interesting. So thoughts on a Lotus birth. So first off, I want to talk about what is a Lotus birth, and I'm going to read the definition from WebMD. Okay, so a Lotus birth is when the umbilical cord is left attached to the placenta instead of being clamped and cut until it falls away on its own. That means that the baby stays connected to the placenta for longer than a typical birth. Typically takes about 5 to 15 days for this to happen. So instead of waiting for that umbilical stump to fall off, you're waiting for the umbilical stump and the placenta to fall off in a traditional Lotus birth. And this is thought to have like an easier entrance into the world. Now, some people consider a Lotus birth when you allow the baby and the placenta to be born completely before cutting and tying the cord or burning the cord, still in that first immediate postpartum period. But when you do it that way, that's one thing. When you do it the other way, you are going to have a dead organ meat connected to your baby via the umbilical cord still, and so there is a risk of infection. So when people typically do a Lotus birth, they would put certain salts and other kind of almost like embalming techniques on that placenta so that it does not start to rot. It also is typically carried around in a little bag. Now, I have not personally witnessed a Lotus birth. It is not something that we see often at our hospital. Sometimes people will ask about it, but given a little bit of education and also an understanding that like you have to kind of come in prepared to have a Lotus birth, to have that true Lotus birth, you need the bag, you need the salts, all of that stuff. Most people are like, oh, I wasn't really prepared for that. I didn't realize that's what a Lotus birth was. Now, your facility, I think it's important to talk with your provider and ask if they have a policy on Lotus birth, ask to see that policy, and then if they don't have a policy, figure out if that's something that you want to do. For me personally, I understand a lot of things, like physiological things, but to me in nature, a Lotus birth isn't something that's truly physiological because all other animals are going to eat that placenta, and that's to protect them from predators and then also to give them some more iron and stuff after giving birth. Now, we as humans don't necessarily need to eat our placentas. That's another conversation for another day. If that's something that you're into, that's totally fine. You do you, girl. But physiologically, that's not something that we would see with the Lotus birth. So I am not the biggest fan. There is a risk of infection, which I think really needs to be addressed. But again, this is your baby, this is your birth. Fully educate yourself on the risks and benefit, talk with your provider, and make the decision that's best for you. But I haven't really seen a Lotus birth in action, and it's not something that I would ever personally choose for myself or my babies. And then I have a couple questions on breastfeeding and pumping that I just wanted to touch on. How can I prevent blocked ducts? I express every 3 to 4 hours. My baby is still in the NICU, not breastfeeding yet. Rosie talks a lot. She's not upset. She's just talking. So, if your baby's still in the NICU, I'm guessing baby's under 12 weeks. So we're still working on establishing our supply. Are you really going to talk all about this? Pumping a little bit more frequently might help every 2 to 3 hours. Fully emptying your breast, so pumping past when the milk stops spraying. Using hands-on massage to help fully empty your breasts as well is going to be helpful. Making sure that your flanges are properly sized. Fun fact, most people are much smaller than the standard 27 and 24 millimeter flanges that come with pumps. I don't know why they come with such large pumps, but there are great inserts and other things that you can buy. You can get a ruler on Amazon, like one of those little circle rulers to measure the millimeters of your nipple. Be My Breast Friend on Instagram has a great sizing tutorial. I will leave that linked for you guys because I think that's really helpful, because having appropriately sized flanges will definitely help empty your breasts. Using heat can be really beneficial, using vibration. Other things that might be beneficial are taking a supplement of sunflower lecithin, which is a fat emulsifier, which will help emulsify those fat globules. That's what gets stuck when you have clogged ducts. And then also meeting with an IBCLC and figuring out, if you're still getting clogged ducts, what other things can be done, what can we work and troubleshoot through, because clogged ducts are no fun. Clogged ducts can lead to mastitis. I have a video all about clogged ducts that I will leave posted for you guys down below as well, or in the iCard or whatever. Tips for exclusive pumpers with their first little one who would like to nurse the next one. Okay, I think the most important thing to do, because I have exclusively pumped and now I am breastfeeding Rosalie, is kind of figuring out, one, why did you need to exclusively pump with your first? What was going on that was happening? Was it a mental health issue? Was it a tie issue? Was it a you're not sure issue? Maybe you want to meet with an IBCLC and figure that out. Was it a supply issue? What was going on? And think about how you can help that thing not to occur with your next baby. So doing a really early work with lactation consultants, getting on medication for your mental health earlier. What can you do? And then also, when you are exclusively breastfeeding and you have exclusively pumped, I think it's really, really difficult to go from the mindset of knowing exactly how much your baby's taking to not knowing how much your baby's taking. I think that can be a really hard thing if you have exclusively pumped and then you're not exclusively pumping, is not knowing how much they're taking, not knowing how much you're expressing every day. Because when you exclusively pump, if you've exclusively pumped, even if you're not a type A person, you can get really type A about it, because you can physically see exactly how much milk you're making. You can know exactly if there's more, if there's less, you can troubleshoot from there. And with the baby, you're not going to get that immediate mathematical feedback, which can be really difficult. Okay, my last question is about antidepressants. So I am experiencing some depression in my pregnancy and am concerned. Can you talk a little bit about that? Yes, 100%. So a lot of people know about postpartum depression. We talk a lot about postpartum depression, but people aren't aware that you can also develop intrapartum depression, which is depression during your pregnancy, and that can be similar to the postpartum depression. And so a big thing is, if you're having these feelings, to talk with your OB about it, to talk with your care provider about it. So, are you feeling better? Are you feeling better? Are you good? Is there more? Oh, blowout. Oh, blowout up the front. Yo. Oh, it's on the bed. No. Just wash this comforter. Are you proud of yourself? Can you look me in the eyes and tell me that you're happy now? Oh my gosh, there's so much poop. Girl, why? Why are you doing this? It is not funny. Hi, I just pooped my pants. And all over the bed. Okay. Let's finish up that thought. If you are experiencing depressive symptoms during your pregnancy, it's really important that you talk with your OB. You can develop depression during your pregnancy. Intrapartum depression is totally a thing, just like postpartum depression is a thing. Now, if you get on medication, and I am a big proponent for medication if that is what you need for your mental health, I think it's so important. There is something that I think that everybody should know, just to be aware and prepared for it. Whenever I have a patient who is on Zoloft, who is on Celexa, who is on whatever depression medication, anxiety medication, and if you're already on those, just listen up because this is important to know. Sometimes your baby will come out, and your baby will be, because of those medications, have a little bit more trouble getting ready for extrauterine life. Their respiratory drive, so their desire to breathe, they're going to be a little bit depressed. They're going to be a little bit too chill, where we want them to be fiery and loud and crying and breathing. This is something that is normal with these medications. This is something that we expect. This is something that does not cause long-term issues, but baby might need a little bit of extra respiratory support for a few minutes, 10 minutes, 20 minutes, just until they figure out, hey, I've been born and I need to breathe on my own. This is not to tell you not to take these medications. I think these medications, if they are a part of your mental health, are really important for the health and safety of you and the health and safety of the baby growing inside of you. This is just something that I want you to be prepared for if it does happen, that it is not unexpected, that your nurse is prepared for it. Obviously, make sure your nurse knows all the medications that you're taking and that they are prepared and they are ready for it and that your baby is going to be okay. Because this can be really stressful during delivery, but we are prepared and we've got you and we've got your baby. So don't stress. Anyway, I hope that this Q&A was helpful. I had a lot of other questions. I might make another video. I'll try and do one every month, every few months. And next time I'll try and do it without the girl who cries, poops, and wants to nurse during it. So until next time, bye guys.